Hello, everyone. Thank you very much for joining us today for our Cardiac College online session. Today's session is about taking your heart medications. My name is Paul O. I'm the medical director in the program. We've had the opportunity to connect on a few occasions over the last couple of weeks, and it's my pleasure to be back with you again. As in previous sessions, we'd just like to remind you of some of our ground rules so that we have a successful session. Remind you that these sessions are for education only. We would suggest that you connect with your healthcare provider if you have a particular question about your situation. We do look forward to taking your questions as we go through this, and we'll remind you about the Q&A function in just a second. We will endeavor to answer your questions in a general sense. It might not be personal, and don't take it personally, please. We may not be able to get to all of the questions today, but we will do our best to answer them promptly and get them posted online. And I think you're very familiar with this process by now. Remind you that we'll take your questions using the Zoom, on the Zoom platform, using the Q&A that is shown with the green arrow in the bottom. Here are the overall objectives for this next 40 minutes or so. This is going to be a slightly longer presentation than our prior ones. Slightly longer than our prior ones in order to cover off a little bit more territory. Again, these sessions are always great when we do them live on site because they get to, we get to have a good conversation about what's important for you, and we get to share with each other. I'm just going to turn on my video at this point just to show you that I am indeed live here today. Okay, so cool, going along. So here's the construct for this this session today. That while we could talk about a whole bunch of medications, and if I was with you today, I would ask you face to face about how many of you are taking medications. And for our patient partners, I would imagine that it is indeed 100% of us, or virtually 100%, that would be taking some sort of medication. And if I ask you the number of them, and if I count it up from 1, 2, 3, 4, 5, and ask you to raise your hands as we went along, then I am sure that many of us are on multiple medications. And then if I followed up and said, how many of you would like some more of these? Then there'd be very few hands that would go up. In fact, you'd wonder, why do I have to take all of the things that I am indeed taking? You know, it's been an interesting adventure. I put interesting in quotation marks. Whether you've had a heart attack or a surgery or an angioplasty or living with some other kind of cardiac condition, then it certainly hasn't been something that you've asked for, and you haven't asked for a medication cocktail. But hopefully by the end of this, we'll appreciate that medications actually do play an important role in our health. And you know, this is a diagram of somebody's coronary artery to demonstrate this notion that indeed parts of our bodies may not behave in the ways that we might intend, that we might wish. And for those of us who are living with atherosclerosis, meaning that we might have had a heart attack or a stroke or blockage in vessels in our legs, or we might have had bypass operation, or an endarterectomy or an angioplasty, then one of the common attributes is that artery, the health of our blood vessels, may not be as good as it might be. And here is an idea of how we could think of the pathology, the visual diagram of what's going on inside of our arteries, and then think about where medications as well as other aspects of health that we touch upon in rehabilitation are actually very important. So medications make sense not when they're given to you in a list or with long words, but when we can think about what they might be doing inside of our bodies in a positive way. We will touch upon some of the side effects and adverse experiences as well that we might be kind of going through on a day-to-day basis. But for now, let's think of this orientation with an artery that might be inside of our heart. And what we're meant to be showing you here is that this artery is meant to be a large open tube where blood is flowing. In this case, there's a bunch of things that have gone wrong. The red ellipse in the middle, this big red circle, is a blood clot that's formed and blocked up this artery. So blood is not flowing in the way that it's intended to. And underlying this is this large pink crescent moon that represents plaque or atherosclerosis. And when that's built up over a long period of time, it can go through a rupturing kind of process at the edge of a thin fibrous cap. And that might be what incites this thrombus from forming. In fact, this is what's happened to this poor individual at the time of a heart attack. The other component is very dynamic in nature, and the blood vessel is meant to be lined by a very fluid moving endothelium, meaning that it compresses and opens and allows blood to travel through in a very smooth fashion. So if the blood vessel health goes off with time as well, our endothelium becomes dysfunctional, then blood does not flow in a particularly good way. So this picture shows us when a plaque goes bad, we have built up a large crescent moon that ruptures, that incites blood to clot, and the internal lining is not working particularly well. This then sets up a framework where we might think about various kinds of medication therapies that can help us along the way. And the next 30 minutes or so are meant to describe where we might think about medication targets to give some sense of why we are taking the things that we are supposed to be taking. Because I know sometimes as a medical professional that I may not do the best job in explaining what's going on with these drugs, but we expect you just to take them. Trust us, there is some sense to them. They do make sense, and let's try to disclose this. Okay, so the first part of the conversation goes with the blood cells. So what makes up that big red center are blood cells. And what we'd like to remind each other about is that there are different kinds of cells that float around in our bloodstream. This is a lovely pictorial that's taken from the bone marrow of a healthy individual. And you will see that we've got these red cells right in the middle here. Oops, let me just go back for a second. I'm just checking the chat as I move along here. As we think about the different kinds of cells in our body, we've got these lovely large red ones that are shaped like discs. And you'll see that there's actually a central part of them that dips in. When they're nice and red or pink and healthy, these are the red blood cells in our system that are carrying oxygen and delivering it from our lungs and our heart down to exercising muscle, releasing oxygen, and then returning back to the lungs to pick up more and moving around. That's a healthy red blood cell system. We also have these ones that are kind of white, or in this case, kind of purple in nature. And these are particularly important in this day and age when we are trying to fight off infections, whether they be viruses like coronavirus or bacterial infections at other times of the year. And they are an important natural defense for us. So we like to have the right number of these cells that are very active and ready to go to war for us. The other unappreciated cell that lives in our bloodstream are these little yellow ones. And we actually have hundreds of trillions of these platelets that are floating around the body. And I've said that they are called platelets. And they are another kind of defense for us if we ever get into trouble and get cut or injured, that they become the cells that can form that defense and help us heal up cuts and other kinds of injuries. This is another version of a blown up picture of these platelets, and you'll see that at rest they look like pancakes or pita breads, and they can stack and unstack and just kind of move forward and backwards, and they're waiting over time to do something. It's an interesting and somewhat tragic story of our platelet, because we've got a huge number of them, trillions of them, that float around in our bloodstream. They have a lifespan of about 7 days, meaning that they are looking for something to do in those 7 days. And in those 7 days, what they are looking to do is stick. And this lovely picture shows you how platelets can actually transform from pancakes or pita breads into things that blow up. And I'll show you my hands like this, that the platelets are showing that same sort of thing. So they stick out, these fingers or fronds in medical pathology terms. These are glycoprotein 2B, 3A receptors that physically express outwards from the platelets. And you could see that they start to reach to each other. And the two at the top, the fingers have kind of overlapped, and now they're going to stick together. This is the magic of how a platelet can move from being quiet at rest to being activated and now ready to stick and plug up into places where there is injury, or places where they think that they need to heal something up. Now, if you've managed to nick yourself shaving, or you've bumped into a table and caused a small cut or abrasion on you, then the platelets are very important to plug up those holes. But since the platelets we've got so many of them floating around, they are also looking for other things to do inside of our bodies. And sometimes they get fooled to some extent. That, for instance, if we return to that image of the artery inside of our body, where there's that crescent moon of the atherosclerosis, and there is a rough edge of a fibrous cap that overlies that, sometimes the platelets think, you know what, that looks like it's an injured surface, and maybe I'm going to go start to stick there. Now, they think that they're doing the right thing by preventing some other kind of injury, but for us, in terms of blood flow, that might not be such a good thing, and this can be the inciting event where things get plugged up. And here is a blown up picture of what a platelet clump will look like when you get a whole bunch of platelets that are stuck together, and then we could put extra fibrous mesh in there to really make it stick together. Now, some of us will have undergone a procedure called an angioplasty with a stent. And what's shown here is this large artery in cross section. Here at the bottom of the artery, we're showing that atherosclerotic plaque. And here, there is a wire with a balloon that's shown in the greenish kind of tone, where now that plaque has been stretched open. And the metal that you see in the wavy pattern, that is a stent that gets left behind to prop this artery open. So this has been a terrific advance in the last couple of decades. So now cardiologists can reach these narrowings and pop them open with a balloon, leave behind the stented wire or the stented mesh to keep these arteries open. And, you know, people can go into hospital and leave the next day with these arteries popped open. You can imagine, though, that at the edges of where this ballooning procedure has happened and where the stent is left behind, that when you start to float platelets by this kind of surface, that they're going to look at this and say, I think I should be doing my job, and my job is to stick to these surfaces. So while we're trying to do good things to these arteries, we may actually also be upsetting our platelet clotting systems at the same time. Now, if we look further deep into what's going on with the platelet, they aren't simply pancakes or pita breads. They're actually very active from a metabolic sense. They've got little bits of machinery. So this represents one platelet that's really blown up now. And what's shown in the middle is this kind of complex chemical cascade that goes inside of this platelet that allows it to get amplified up to start to stick out these fingers and then cross-link with another platelet. And the first point that I want to make is that one of the central kind of chemical pathways that happens in the middle is this central thing that's called CO, or cyclooxygenase. This is one of the key metabolic steps that gets triggered, that gets activated so that platelets start to stick to each other. Why do I highlight this? Is that if we can identify a particular chemical or enzyme target within any kind of cell in the body, then we might think, well, here is a drug that could come in and kind of block this. So if I asked you the question, what is the pharmaceutical agent or the medication that addresses this cyclooxygenase in a platelet, you might not be able to answer that question so clearly. But on the other hand, if I asked the people online, which of you are taking some kind of medication for the heart, whether you had a heart attack, a stroke, an angioplasty, a surgery, what is the most common medication that would that would be applicable to all of you. And I think you all might say that it's an aspirin, and probably just a little baby aspirin. And that's true in Canada, it's true in the United States, it's true elsewhere around the world. And why are we taking the aspirin? Well, here's the answer on this slide, that aspirin actually will attach to this little enzyme in the middle called cyclooxygenase, so that we can reduce the amount of sticky substances that come out of the platelets, including this guy here called thromboxane A2. And then it would be no surprise to you that if we looked at a large number of studies that have been occurring over many decades, that if we look at the number of people that might experience a bad thing, like a vascular event overall, like a heart attack or a stroke, or strokes alone or heart attacks alone, if we look at people taking aspirin, shown in the orange bar, versus people that don't take aspirin, shown in the purple bar, then very consistently, there is a reduction in risk of about 25% simply by taking a baby aspirin in preventing heart attacks or stroke. Aspirin works very well to prevent secondary events, ... But the astute ones on the line, and I know that's all of you, would say, well, the orange bar is definitely better than the purple bar, but still in the orange bars, there are still a number of people that are experiencing strokes and heart attacks. So maybe there's something else we need to think about vis-a-vis the platelet. And the way I think about platelets are like the kids, especially little young boys. They're in the back of the car. And any of you that have been on a road trip, maybe not recently, but in years past, months past, I'm sure we've been on road trips with kids in the car. And you will inevitably, after some period on the road, look back or hear the kids kind of poking at each other, aren't they? And these kids demonstrated very well that the boy in the gray sweatshirt is putting his hand onto the head of the one in the red, and the one in the red is sticking his hand out here. Imagine that these are actually two platelets with their hands sticking out, with their glycoprotein 2B3 receptors that are expressing. And at the bottom of this picture, you can actually see that they're holding hands, holding on to each other. So this is what platelets do. If you had kids in your car, you would tell them, keep your hands to yourself. And they might listen to you for a little while. That's like giving platelets an aspirin. But after a few minutes, you know they're going to be back at it. Platelets are the same way. You have to tell them not only once, but maybe twice, maybe 3 times. Keep your hands to yourself. So here are some other targets around this platelet where we can tell them, don't be so sticky. Cyclooxygenase is one of them, and we already heard what the medication there might be, using aspirin, because that reduces the amount of this stuff called thromboxane that actually comes out of the platelet that makes platelets stick. And over the last couple of decades, we've also discovered that this substance here called ADP, or adenosine diphosphate, is another very strong way of attracting platelets and getting them to express their receptors to stick to each other. So, as we said, if you can identify a target on a cell or within a cell or along a pathway, then you can think about medications that can be developed to hit those targets. We've already said, well, aspirin is a great way of hitting the cyclooxygenase or the thromboxane, but given the platelets are like kids and they like to stick out their hands and they like to stick to each other, then we might need some medications over on this side for the adenosine diphosphate. And that's why we have other medications like clopidogrel or ticagrelor. Its other name is called Brilinta. Prasugrel, its other name is called Effient. And those of you who have undergone an angioplasty with a stent, if you look at your drug list, then you'll recognize that you're probably taking an aspirin and you're probably taking one of these medications as well in combination to keep these platelets less sticky. Because if you've gone through that procedure with the wire and the balloon and the stenting, then that is a particularly sticky situation. And that's what's shown in this diagram here, that after the stent has been hanging around for days or weeks or even months, the platelets, as they float by, they still like to stick to that. So we need to use combinations of medications for 6 to 12 months to prevent this thrombosis from happening. The good news is, over time, the stents will heal. that we may regrow some lining cells to coat it and to smoothen it out. And then we can reduce the intensity of these medications. Because we know while medications might be good, including these antiplatelet drugs, to prevent heart attack and stroke and other bad things, we know that there is also downsides. So with every medication, there's good things. With every medication, there might be some downsides. And all of you would be able to tell me that the downsides of some of these antiplatelet drugs or blood thinning medications is that we might end up with bruises and or bleeding. A minor bruise is okay. And if we were together in the same room, I might even ask you to roll up your sleeves or roll up your pant legs and show me who's got a bruise. We might even have a competition on who's got the shiniest, most purple bruise. Of course, I'm being glib and facetious about that. I don't want anybody to have bruising. But if you got one and you've got one that you didn't ask for, in a positive way, we can think about it as this is a sign your drugs are actually working. This is a sign that your aspirin or clopidogrel or ticagrelor or prasugrel are working because they are thinning out the platelets, preventing them from sticking, and you might end up with some of these bruises. You might end up with even some other kinds of minor bleeding, like you might have experienced a nosebleed through the winter if the air was dry and things got cracked. Or for people after a shaving episode, if you've nicked yourself, then you may bleed for a slightly longer time than you did before. Again, it will stop with pressure. The platelets still have some activity to them. And if you just keep pressure for long enough, the bleeding will stop. Now, when do we have to be kind of more concerned is that we need to watch when there might be more severe bleeding going on, such as if you're vomiting blood, that's clearly a bad thing. If you see blood coming out in the bowel movements, or if your bowel movements turn dark black, then those are signs that there might be internal bleeding. Get to your doctor or get to the emergency department right away. Even in this time of coronavirus, this is something that needs attention right away. Okay. So that is our antiplatelet story. If you've got questions about antiplatelet drugs, please feel free to fire those into the Q&A, and I will pick them up towards the end of the session. I'm going to move along thinking about the cascade of when things go bad in our plaques and think about the next kind of category. This animated cartoon reminds us that the heart is beating, and we could do a quick check-in to make sure everybody's heart is indeed beating. That will remind you that we don't have to tell our hearts to beat. It just keeps going and going on its own if everything is working well. The heart has its own electrical system. The heart is influenced by different chemical signals to make it go faster or slower. And one of the ways that we can manage that is with medications, because sometimes we will want to slow things down. One of the quick questions that comes up is the heart a muscle or an organ? And indeed, I can say that it's actually both. That we think of the organs as the big things inside of us, and it happens to be the heart is one of the most important organs, and it happens to be made pretty much entirely of muscle tissue, a special kind of muscle that allows it to squeeze and open and squeeze and open. It's a muscle. One of the chemical signals that tells the heart to beat how fast and how forcefully is a chemical signal called adrenaline. And one of the ways that we can influence that is with medications like these ones called beta blockers. Now, you may or may not know that you're on a beta blocker, so we like to break down sometimes the medications into ways that can actually be recognizable. So we call this group of drugs the LOLs or the LOLs. And you'll recognize that you're on a beta blocker if it ends in LOL. So here we have, for example, propranolol. More common ones that we might be taking today, metoprolol, bisoprolol, atenolol. There's many others that have this same sort of cadence. And the reason that we are taking these is that we sometimes want to regulate what goes on with our heartbeats. And to kind of build the story together, our hearts are muscles. They're beating on their own. Sometimes we get stimuli that makes our hearts go a flutter. So we know that we might get a chemical signal like adrenaline that allows us to fight or flight. So if on a walk today where we're going to encounter a very large bear, then our bodies would tell us this is not a good situation. We should either be ready to fight this bear or preferably run away from the bear. And we'll find that our hearts start to speed up. They'll beat more forcefully. You don't have to tell yourself that. There is a strong connection between your brain and the internal organs in your body, like the adrenal glands, that pump out this stuff called adrenaline that gets you ready for this. And that's a very good kind of system that will allow you to survive well in challenging environments, like with wildlife. The challenge becomes, though, that some of us might have had an experience like having had a heart attack or a heart surgery that is similarly stressful. And while we might want our heartbeats to be high and our blood pressures to be high so that we can get ready to fight or run away from something, if we're trying to recover from a surgery or something else going on, this may not be the friendliest situation for us. And that's why we think about using those LOL drugs to really calm things down. Okay, I'm going to pause for just 1 second and see about questions. Okay. I'm going to come back to some of these questions later on. So the reason for using these beta blockers then is to slow down the heart, bring down blood pressure, relax the heart to some extent. Heart rates go down, blood pressure goes down. There's the work or stress the heart. You can imagine this is a much nicer way of healing from the heart attack, healing from the surgery. Or if you're living with constant high blood pressure, this is a good way of calming things down. And you wouldn't be surprised then to learn that for many people, if you've had a heart attack and you've had high blood pressure, and if you've had some damage to your heart, that if you're taking these kinds of medications over a medium to long term, then this can reduce the chance of having another heart attack or an episode of heart failure. Or some people are using this to regulate heartbeats if we're prone to having rapid heartbeats or heart rhythms or atrial fibrillation. That's good, right? We're even feeling calm. I'm feeling calmer now talking about this kind of medication. And what we might feel then is some sense that, boy, we're really getting sedate. We're really getting calm. Boy, this webinar has taken a strange turn where we're getting kind of bored, aren't we? And that's what we might see with beta blockers, that, ooh, we turned into a turtle. The side effects of beta blockers might be, well, hearts can get too low, or our blood pressures might get too low, and we might not have the energy and the pep that we might want it to. For some people with asthma, there is this kind of crosstalk of the beta receptors with our lungs and our heart. And if we block those beta receptors, if you're prone to having asthma and shortness of breath, then the beta blockers might trigger some of that shortness of breath. If you're living with diabetes, one of the responses to low blood sugar is for heart rate to go up and blood pressure to go up. And so sometimes they can get masked for some individuals if you're on a beta blocker. And for the brain parts of us, if we get slowed down, then you might feel really tired, or some people feel like their mood has gone low, or some people get disturbance of their sleep. So of all the medications that we might offer you, this is a very important category. It can do really good things by calming down the system, but some people have challenges with these medications as well. And that's sometimes why finding the right dose that works for you can be very important. So if you think that you're experiencing any issues, then do chat about this with your doc or your pharmacist. Okay, moving on to our third category, because I don't want to keep you here forever, but I'm having fun with this, that we might think now about that big crescent moon, that plaque of atherosclerosis or cholesterol that lives there, and remind you that this is something that just didn't occur overnight. This is something that's built up over many years, indeed for over decades for some individuals. Surely there must be something that we can do about those things. And indeed that there is. The first part of the story starts with kind of a throwing back to just thinking about where cholesterol comes from. And we often think about cholesterol in our diet and making strides to changing the amount of cholesterol that we might eat from animal proteins. And that's very important. But I'm just going to remind you, for most people, typically about 25% of the cholesterol comes from diet. Instead, the balance, the vast majority of cholesterol, 75%, is actually coming from us internally. And that big organ that's shaped in a triangle is the liver, and that lives in the right upper part of your abdomen. And it's responsible for making all kinds of important substances vital for our lives. And it's also responsible for making cholesterol. Why cholesterol? You think, well, cholesterol is kind of a bad thing, isn't it? That's the stuff that plugs up my arteries. And that's entirely true, but cholesterol also has some important basic functions, like making up the walls of every cell in our body, like making hormones like estrogen and testosterone, so differentiating boys and girls, making bile acids that allows us to digest fats in our diets. It's helpful for the formation of some of the vitamin systems in our body as well. So without cholesterol completely, we would be in trouble. The issue comes, though, when we might, over time, have been in a place where we might have had the opportunity to eat as much cholesterol as we wanted and have our livers producing as much cholesterol as we wanted. And maybe we've also inherited some genes that would make us even overproduce cholesterol. And you can imagine if that happens, then some bad things will happen. Cholesterol coming in is built up from building blocks. And in this case, I'm just breaking it down into a couple of key steps. So small molecules like acetyl-CoA join with medium-sized one, acetyl-acetyl-CoA, into intermediate products like mevalonate that eventually produce into cholesterol. And cholesterol, if we've got a lot of it, is carried around on particles like LDL that eventually make it up into our blood vessels. So understanding this kind of pathway and the key factories, we can start to dive in and figure out, wow, there is this stuff called HMG-CoA reductase that's inside of our livers. And if that thing is active, that actually leads to a lot of production of cholesterol. And if it's overactive in our systems overall, then that can lead to this cholesterol deposition. We've already had this story that if we can understand what the body's doing, maybe we can think of ways of blocking some of this from happening. And indeed, in this pathway, that we can think, there's something that I can do. Because we know if we're living with a heart condition or diabetes or risk factors like high blood pressure or family history, then ideally we would like this LDL cholesterol to drop below 2. How am I going to do that? Well, I can change what I eat, and that's really, really important. But if I really want to have a bigger impact on the cholesterol, then I've got to do something inside my liver. And inside this pathway, maybe I can do something to the HMG-CoA reductase. So if I asked you the question, can anybody tell me what an HMG-CoA reductase blocker might be? You might not be able to answer that question, but you actually all do know the answer to this question. And the answer is, this is where a so-called statin drug comes in. Statin is a made-up name. Statin is the short form for the whole family of drugs. Like we had the beta blockers that all ended in LOL. Statins are called statins because they all end in statin. The long name for these guys is HMG-CoA reductase inhibitors. That's an interesting clue, that they block that factory that's responsible in large part for production of cholesterol. There's a number of different kinds of statins available in Canada and the US. Here's an example of 6 of them that have been onto the market at various points. And you'll see that they really differ by the amount of LDL lowering that they can achieve. Some of these products have a relatively lower effect on LDL lowering, while some of these newer ones can lower cholesterol quite a lot. And for those of you online, if we asked a poll of which of these statins are you taking, I would predict that the vast majority of you would be taking rosuvastatin or atorvastatin. And you can see the reason that we're taking those is that they have the best effect on LDL lowering. And indeed, our desired target is to try to get our cholesterol down at least 50% from wherever it started. If it was very high, try to bring it down. But even if it was in the middle, bring it down another 50% is a lovely idea, because what that hopefully does for us, if we can block the HMG-CoA reductase, reduce the amount of cholesterol coming out of our livers, is that we can change now the balance of, instead cholesterol depositing in our arteries, maybe we can actually start to pick up some of the cholesterol out of our arteries. And indeed, long-term or medium-term studies, like a year or a year and a half, if you're taking one of the higher potency statins, you can start to see positive effects on the cholesterol that's sitting in the walls of our artery, and you can start to see the arteries open up. That is a very exciting way of reversing some of the bad things that have built up over decades. Now, if you can't take one of the statin drugs, and we'll talk about side effects in just one second, that there are some other options, like these drugs that are called bile acid sequestrants or resins. The way that they work is you're basically drinking small beads or what feels like sand. They go into the gut and bind up cholesterol that's circulating through the gut. There's not a large amount that goes through there, so you'll have a modest effect on cholesterol. Some of you may be taking this drug called ezetimibe that blocks cholesterol from getting in through the gut. Again, smallish effect, but can be very important. The newest kinds of drugs are these guys, and some of you might be on injectable forms of cholesterol therapy, and it's taking advantage of this kind of real cutting edge type of approach to lowering cholesterol that looks at the idea that not only can we affect cholesterol as it comes out of the liver, but we can also look at how cholesterol might get into the liver as a recycling kind of phenomenon. So this large gray mass here represents a blown up picture of a liver cell. And what we're trying to show you here is that these brown squiggles represent receptors for LDL particles that are these blue and yellow tennis balls. So within the LDL particle is cholesterol. And normally what happens is cholesterol will bind to this LDL receptor and get brought into the liver cell to get digested and broken down. The third part of this relationship are these little pinkish things that look like beans. These are molecular, or these are little particles that are called proprotein convertase subtolixin type 9. Oh my God, that's impossible. So we call these things PCSK9. And what it is just like a three-way now signal that happens between the cholesterol particle, the receptor, and this PCSK9. And when those three things get internalized into a particle within the liver cell, essentially all of it gets sent into a factory and it all gets broken down. You could say, well, that's not very environmentally kind of friendly, because I love these LDL receptors that just grab cholesterol from the environment and bring it in. So one kind of really smart thought that's emerged in about the last 5 years is I could maybe change this pathway here where these three things are happening. Because when those three things happen, we lose our LDL receptors. So what if instead I figured out a way to block this PCSK9 particle? And if I injected these things that look like blue Ys, these are antibodies that can be injected into the body with a very specific target of these PCSK9 particles. So I can bind them all into the circulation, and now the LDL cholesterol particle is free to attach to an LDL receptor. When it comes into the liver cell now, I have a very different kind of transformation that happens. The LDL particle goes to the factory and is broken down, and its component parts are broken up. But lovely thing that happens is that these receptors get recycled and sent back to the surface so they can grab more LDL particles. So this is the cool stuff. These PCSK9 inhibitors that block up these third particles that now allows more LDL cholesterol to get recycled into the liver. And the net effect is lowering the cholesterol by another 50%. So for some of you that are living with very high cholesterols because of genetics, or your bodies just aren't responding to those statin drugs, or there's a lot of atherosclerosis going around, then some of you may be invited into a conversation about using some of these other medications. As we've always said, that there is some balance. There's some good things for the cholesterol therapy, so there's some downsides as well. And some of the common side effects of cholesterol medications might include muscle aches and pains. These are the most common things that we hear. The tricky thing is to sort out whether this is a muscle ache and pain that's related to the cholesterol medication, or is this a muscle ache and pain that's related to life? Because all of us have aches and pains of some sorts. The ones that are typical of the cholesterol medications are that it will typically affect a big muscle, like the big shoulder muscles or the back muscle or the thighs. If it's related to the drug, since the drugs are in your body all day long, then you might feel this all day long as well, as opposed to episodically that relate to an exercise episode or something like that. And if you and your doctor agree that you might try starting the drug, stopping the drug, starting the drug, stopping the drug, and looking for the pattern related to the medication, then clearly if it's related to the medication, then it'll be temporally or in time related to when the drug is on and goes away when the drug is off. So those are some of the thinkings that can be done. And through this sort of thinking, then you might end up on different kinds of combinations of medications that agree best with you. The point of all this was that cholesterol is something that we can modify in a big way. We can drop the levels a whole lot, and that can really improve the health of our blood vessels. Moving on in the last few minutes here is another thought about our blood vessels, and we introduced the idea that the blood vessels are not just simple tubes. They're not straws or pipes, but rather that they're very dynamic and they open or close. And they've got this lovely lining to them that's called endothelium that allows things to flow in a very smooth way. Now, some of the substances that act on our blood vessels actually will cause them to squeeze and contract down. And one of these active hormones is called angiotensin. We talked about this before a couple of weeks ago in light of some of the controversies around COVID-19 and certain medications. So I'm just calling back to that we have this substance in our body called angiotensin. And if you broke down that word, I'll remind you that some of us have had angiograms or angioplasties, and this refers to the heart and blood vessels. And tense refers to tense, or things that make our blood vessels squeeze down. And this is the picture that I have in mind when I think about angiotensin, that we have hormones that make our vessels squeeze down. Understandably, that would make blood pressure go up, and it would make blood vessels dysfunctional and blood flow not as good as it needs to be. Angiotensin. This can be a survival thing for us if our blood pressure is low for some reason, that we've been injured or in the desert and losing fluids, that we might need some angiotensin on board to squeeze and keep the blood pressure up. But for others of us, we might be squeezing like this too often. Some of us with high blood pressure or some of us affected with heart conditions might have vessels that are doing this too often. So we have medications that can change the way the angiotensin system works on our blood vessels. The ACE inhibitors block formation of angiotensin. We recognize them because they end in pril, and there is the pattern: enalapril, ramipril, lisinopril, perindopril. You've got that cadence. Their cousins are drugs called angiotensin receptor blockers, and you'll recognize them because they end in sartan, and there's the various categories of these things: candesartan, irbesartan, olmesartan, etc. They block the action of angiotensin. The thing common to both of them is blood vessels, instead of squeezing, are going to relax. And the net effect, of course, blood pressure comes down. Blood flow will be smoother. And over time, what's been seen for people is the chance of having a heart attack or a stroke or a heart failure event goes down nicely. For people living with diabetes, you might be offered up these medications because if we can relax the blood, the blood pressure right in the kidneys, reduce the stress there, the kidneys will be happier over time as well. So they have lots of good things associated with them. They also might have some bad things, as we said. Oh, the turtle doesn't belong there. What I meant to show you was somebody coughing instead of a turtle. But with the ACE inhibitors in particular, about 5% of people may develop a dry, irritating cough that's there through the day and night. Not dangerous by itself, but just certainly irritating. And if that happens, sometimes what you and your doctor may do is decide to switch from the ACE inhibitor, the pril, to the other side, the cousin, to the sartan, and that will usually remedy that situation. With both the prils and the sartans, and indeed for many of the blood pressure drugs, what may happen is that your blood pressure may feel low, and you may feel a little bit dizzy, or vision may go a little bit gray or a little bit black. You may see some stars for a few seconds if your blood pressure is very low. And the caution we would offer up, if you're feeling that way, is you should take your time. If you're getting up out of a chair, go slowly. So maybe the turtle applies. If you're getting up out of bed, then take the time to sit on the edge of your bed for 30 seconds before jumping up and getting on with your day. Take some time, allow the blood flow to move to where it needs to be, and back up to your head in particular before moving along. So the conversation that we've had is around this blood vessel that's gone bad. And we've described a number of ways of addressing the abnormalities that occur here through medications and thinking about specific targets. We think about the thrombus and how platelets might lead to sticking in these areas with or without a stent in place, and the important role for drugs like aspirin and clopidogrel and ticagrelor and prasugrel. We can think about ways to improve the lining of the artery so that it's more relaxed through the prils and the sartans. We can think of ways of reducing the amount of cholesterol or the instability of the cholesterol in the artery through all the different medications that can lower cholesterol and even reduce inflammation. And we can think about how we can relax the overall system, relax the beating heart through using drugs like the beta blockers that can slow things, calm down the system. And the net effect of all of this stuff is that we can reduce the chance of having heart attacks, reduce the chance of having strokes, reduce the chance of having rhythm problems, reduce the chance of dying indeed. So that's a longer explanation about why you are taking all the drugs that you are taking. If you have more questions about this, I'll remind you that your pharmacist is a wonderful ally and has a wealth of knowledge. For people who live in Ontario, you have the opportunity to book in to see your pharmacist to review the many medications that you might be taking. And there's a program called Meds Check in Ontario. There are likely similar sort of opportunities in your own jurisdictions. A couple of other thoughts about medications in general before turning to questions is, to the extent possible, try to take them on the schedule that they're intended. I recognize this can be challenging, and we may forget the occasional one. If it's within a few hours of the time that you were supposed to take them, then just catch up. If it's been a long interval since you've missed the medication, then you could just skip it and take the next one at the right kind of schedule. Avoid abruptly stopping these medications. Some of them have this rebound phenomenon where things can abruptly get worse, like your blood pressure may suddenly go up very quickly if you skip a bunch of doses of your beta blockers as well. And if you're looking for ways of remembering some of this stuff, then talk to your pharmacist. Maybe they can give you something like this, a blister pack or a dosette device where you can keep track of morning, afternoon, and evening. When and if we start traveling again, let's all look forward to that. And we'll plan way ahead of remembering to take our medications with us and make sure we carry them in a bag with us on the airplane, or keep them in the car or in the train. Carry a list of your medications with you, with your pharmacist number or your doctor number, just in case somebody ever has a question about that. And if you wanted more information than I've conveyed, then remind you that we've got some great tools for that, online in the Cardiac College. There's great sections in the toolbox for managing your condition. And one of the booklets that we have is specifically about taking your heart medications. And one of the Thrive videos is devoted to taking your medications. And I would recommend these things highly to you. All right, so let's see what kind of questions have accrued. One question is that not everybody, of course, has this atherosclerosis business. Some people have had valve replacements. And depending on which kind of valve, you may be offered a different kind of blood thinning. If you've had a tissue valve, for instance, then the idea is that you may just not want platelets to stick to the valve itself. and it's not a very intensely sticky surface. So just taking a baby aspirin on its own might be quite enough over the long term, because that's a reasonable balance between bleeding and keeping the blood thin. On the other hand, some people have had metal valves that have been put in, and aspirin alone is not enough in that situation. In fact, you need something a whole lot stronger. So drugs like warfarin or Coumadin are used routinely if you've got a metal valve inside of you to really thin the blood out, because the metal can be very strongly attracting to the platelets and other parts of the blood coagulation system. Another question is, if due to a lack of exercise, should we be changing medication dosage? And I would say no, not necessarily. You know, it's interesting that one of the things that we say always is the way you can make medications better is to take them for a walk. Take your aspirin, take your cholesterol medications. If you couple them with a regular exercise program, everything actually works better. I guess the flip of that would be, if you're not exercising, please continue to take your medication, because there is that defense that your medicines will offer you. But doing both together is even better. So I want you to exercise, and I want you to eat well, and I want you to take your medications as well. So that's great. Question or comment from one of our colleagues on the phone indicating that that this has been some helpful information, and I'm very glad for that, and thank you for that commentary. Another question is, how do you decide which medications to use? Because there are so many in any given category. And yeah, so that's a great question, because, you know, theoretically there's a dozen beta blockers and a dozen ACE inhibitors and a dozen sartans and, you know, 6 different statin drugs. So amongst the whole category, there's usually 2 or 3 or 4 kind of top candidates. And the ideas might be, in general, we might like to try to take drugs that work for a long period of time, like 24 hours. So you only have to take it once a day. That's good for you to remember, and it's good for you in terms of the action on your body. And then with certain medications, we might like to choose the ones that might have the best desired effects on the body. Like with the cholesterol ones, we might pick the ones that have the most cholesterol lowering, which might reduce it to 2 options. The other thing is that you and your doctor will probably have a certain rhythm, and your doc may be most familiar with a couple of drugs that they're very comfortable with in terms of how they work, how the dosing works, how they tolerate. And I think that's a very important place to reach for. And you yourself may have some ideas on what agrees with you or not. And that's true for the beta blocker drugs. That's true for the statin drugs, that I've seen many people that of the many that you've tried, there's only certain ones that might work the best for you. So that's how you might make some sense of all of that and come to a few good choices for you out of the very many. Okay, thanks for that question. Next up is, can we take vitamin C and vitamin D with our heart meds? And the short answer is yes. I think you can do that, and you don't need to worry about it too much with the usual heart medications that we are taking. Next question goes back to, how do you choose the best statin drug? And again, the attributes would be long-lasting, the ones that will give you the best lowering of cholesterol, and the atorvastatin, rosuvastatin probably fulfill that. And then the third one is the one that agrees with you, and that what might mean that only some of them might, one or another might be the one that kind of fits you the best. Next question was around progress or knowledge about ACE inhibitors and COVID-19. When we did the session a couple of weeks ago, we were talking about the theoretical concerns about using ACE inhibitor drugs if you happen to get infected, that it might make the infection worse. But the reality is that I think most people that have looked carefully at this data with the evidence to date have not really been able to show that there's a definitive link between that. And that's coupled with the information that if we told everybody stop their ACE inhibitors, if you're taking them for a very good reason, then we might actually be exposing you to harm. If the ACE inhibitor is bringing down your blood pressure or protecting your heart, then there's a good reason why you should be taking it. So don't stop it. And the other parts are, we should do everything that we can to avoid a COVID-19 infection, which is all the other good things like doing education online and being active in our homes and doing all the physical distancing. Thank you. comment about an aortic valve that was replaced with a bovine stent. So that's another situation where this is tissue valve. Aspirin would be the thing that you might be using. Next question about the types of stents. Are the only types of stents that are being used the drug-eluting stents? Is there any downside, or are they superior to non-drug-eluting stents? And it depends on where we are. In Ontario currently, the last time I asked about this, about half the stents that were being used were these drug-eluting stents. Half of them were the plain metal stents. They both work very well at keeping the arteries open. They're the same kind of metal, but the drug-eluting stent has the extra feature of releasing some extra medication slowly that tries to prevent the arteries from scarring down and collapsing. So the drug-eluting stents tend to be used in areas where you don't want that to happen. Now, you don't want that to happen anywhere, but if you can find a segment of artery that's short and big, and you can put in a piece of metal and that'll keep it open nicely, then you may not need that drug-eluting stent. The downside of the drug-eluting stent is it takes a little bit longer for it to, quotation mark, heal over time, and you might need to use the stronger blood thinning medications over a longer period of time. So that's the bit of a trade-off. I'm going to get to 2 more questions, and then we'll end it together. But terrific. Is there a better time to take a cholesterol medication, like at bedtime? And it's true that we might try to time some of our medications to where things are happening with the body. And cholesterol tends to be produced, for the most part, in the body at nighttime. So for that reason, that previously we used to recommend taking your cholesterol meds at night. But with the newer ones, like atorvastatin, rosuvastatin, they're very long duration of action. It's not so critical. So as long as you remember to take it at any time of the day, I'm happy with that. And the last thing I'll say, and then if there's any more, we'll answer these questions online through the written document. If you take several meds together, are there complications? Because that's what we're asking you to do, aren't we? We're asking you to take 3 or 4 or 5 or 10 different drugs together. And for the most part, the cocktail that we've talked about, the drugs that thin your blood, the ones that slow down your heart, the beta blockers, the statin medications, the prill drugs, they all work in a very complementary fashion. They don't butt up against each other. You can take them together and you'll do very well. But if you're finding that there's some challenges, if you're not feeling perfectly well, you can space them out, talk to your doctor and your pharmacist, and that can work equally well. Wow, that's been a fun session. I hope you've enjoyed it. I'm exhausted from doing this, but it was my pleasure to be able to join you today for this hour. I hope you've found it informative. Thank you very much for spending the hour with us with the Cardiac College online. Again, I see a number of questions in the chat and in the Q&A, and we'll come back to those in very short order. And we'll remind you that we'll be into Nutrition Wednesdays tomorrow. Tomorrow's session will be called Heart Healthy Ways of Eating. Please come back and join us tomorrow. Thank you.